We're going to go live now. Just give it a second. Good evening to everybody. We're really happy to have you all with us on this live broadcast this evening. My name is Miranda van Dam, and I'm the chairperson of the AXPAR. Good evening to everybody. We're really happy to have you all with us on this live broadcast this evening. Cathy, just give me a second. I'm going to just start again. My name is Miranda van Dam. I'm the chairperson of the AXPAR Association, a support group for patients with AXPAR in South Africa. The Voice of the Patient and Expert is a program designed to bring not only live witness, but also to educate and support you at home. Tonight, we welcome Dr. Cathy Spargo. Dr. Catherine Spargo studied medicine at the University of Cape Town before qualifying as a specialist rheumatologist at the College of Medicine, South Africa. Dr. Spargo has worked at a number of hospitals, both locally and internationally, including Ernest Oppenheimer in Welkom, Derryford Hospital in England, and Groote Schuur in Cape Town. She currently works as a rheumatologist and physician in Pinelands, Cape Town. Dr. Spargo and I met in 2016 when I was finally diagnosed with AXPAR. She is also my specialist. Good evening, Dr. Spargo. It's so great to be with you. Good evening. We just wanted to thank you for your time and, of course, chatting to us this evening. You're very close to my heart. Not only do I rate you one of the best specialists in the country, but you've also been my specialist, and you are such a critical part of my chain with my treatment of AXPAR. I thought I'd start off with asking you, why did you decide to become a rheumatologist? Why did you enter into that specialty?
Well, first of all, thank you very, very much. And thank you to all of you that are watching. It's an amazing initiative. I think in South Africa, we have so few patient advocate groups that it's really wonderful to see this group starting to take off. And it's very important, I think, for the patients to be really empowered and to have lots of knowledge about their disease. So I think groups like this are really amazing and important. And probably completely underestimated. So in the long term, I hope that all of you will see the fruits of what you've been doing. And yeah, I love rheumatology. It's an amazing specialty. I think the first thing to say is that, you know, to do rheumatology, primarily you have to be a physician. So that allows us to manage all the problems that go with the actual rheumatological problem. So the diabetes and the hypertension and the cholesterol, whatever else is problematic in patients who might have rheumatic diseases. And the other thing is that the scope of rheumatology is so broad that, you know, it covers in osteoporosis and rheumatoid and obviously the spondyloarthropathies as well. But because it's so broad, we need to have that base as being physicians. And then you subspecialize or super specialize in rheumatology. And you have to make that decision quite early on in your career as to whether or not you're going to do a medical speciality or a surgical speciality. And so I definitely knew that I wanted to do a non-surgical specialty. And then I could have stayed as a general physician, or I thought about dermatology. I definitely didn't want critically ill patients. I don't like ICUs, and I don't like patients dying on me. So I thought about dermatology and then rheumatology, and I had a family friend who was a rheumatologist. So one of the problems, I think, and we're going to talk about this as well, is that there's so few rheumatologist role models, really. Lots of people haven't met a rheumatologist, and it's not really a dime a dozen. So I was fortunate enough to know a rheumatologist and to be able to speak to him, and he really, really, really encouraged me to do rheumatology, partly because there weren't many rheumatologists. So it was between rheumatology and dermatology and rheumatology one. And I mean, they're both what we call clean specialties. So there's no blood and no scalpels, and it's really, I mean, as I said, it's extremely satisfying and it's very broad. So there's never a dull day in rheumatology, and we amazingly lucky to live in an era where there's so many advances as well. So it's not like we keep doing the same thing all the time. We're always exposed to new problems and new solutions, which is fantastic.
Sure, it sounds like the field is much bigger than one actually really thinks, hearing you
Yeah,
talk about it.
yeah, it is very broad.
So if we think about, if we look at the stats that's available to us, which basically gives us one rheumatologist to every 650,000 patients, what kind of a picture what does your workload look like? I mean, it clearly doesn't seem like we have enough specialists in our country to work with all the patients.
Yeah. I mean, we definitely don't. And then the problem is, number one, that it's not always seen as a glamorous side of medicine. So there are specialities which people perceive as either better reimbursed or more dramatic or more glamorous for whatever reason. So rheumatology is what's sort of classified as a relatively low key speciality in terms of demand. So not a lot of people really consider rheumatology, and maybe that's our fault for not really putting it out there enough. But it's actually an international problem. So there are really not enough rheumatologists throughout the world. So South Africa isn't unique in that regard. And if you look at somewhere like even in the United States, there are some states in America that don't have a rheumatologist as well. So we are bad. And, our cities are relatively sort of well supplied with rheumatologists compared to rural areas. But that's an international problem. And the problem is, as well as the population ages, there are a lot of joint issues that are more prevalent as you age. And so we do need rheumatologists. So your spondyloarthropathies are quite unique in that a lot of the patients are quite young, but we need rheumatologists for the elderly as well. So we're going to have to, I mean, throughout the world, we basically need to train more rheumatologists. And until we train more, we just won't have enough. And if the few rheumatologists in South Africa that are graduating decide to immigrate, then the problem is just an ongoing problem. But we only really graduate between 2 and 8 new rheumatologists a year in South Africa. So it's really a very limited number.
Well, that is a small number of people that graduate every year.
Yeah.
And Dr. Spargo, what do you, a hot topic at the moment is the delay in diagnosis of AXPAR. And there seems to be a huge delay in diagnosis across the world. What would you say would be the big reasons for the delay in diagnosis in our own country? Why would it take up to 8 years for patients to actually get to the diagnosis?
Well, I think that's a very good question, and it's a very difficult question. And, the easy part is actually when the patient gets to the rheumatologist, or it's relatively easy. But because there are a limited number of rheumatologists, and because it's quite difficult to get to see them, it's actually, that's part of the battle. But if the doctors that are seeing the patients initially don't think about an inflammatory cause for back pain, then they don't think about referring. So one of the key things that I tell my patients, whether they are rheumatoid or whether they're osteoarthritis or whether they're an ANC-SPON, when I see them at their first consultation, I draw them a little picture and I try and differentiate inflammatory pain from mechanical pain. And if you don't listen to back pain patients and pick up the clues that there's inflammation there, then in fact you're going to miss those patients as needing referral. So the other problem is that not all patients describe the classical symptoms. So I'm sure that most of you would know that inflammatory back pain is worse in the morning and it may wake you at night, and it's worse early hours of the morning if you need to go to the bathroom, and then it gets better as you move around during the day. But if you don't really carefully ask patients about that, if you don't ask them what time of day their pain is worse, if you don't ask them whether they actually feel stiff in the morning or whether they feel better with exercise, if you don't tease out those facts, you're definitely going to miss the opportunity to try and find an inflammatory cause for the back pain. And I think the other problem is that because unfortunately MRIs are very expensive, most patients actually don't really have radiology. And because that's often important, but not always essential, again, everyone gets lumped in the same wagon. You know, back pain is treated with physio and anti-inflammatories without, you know, the treating doctors really thinking about the underlying potential causes. And so, and because there are lots of patients that just keep going to physios and chiropractors without necessarily looking any further themselves, that's also a tricky, you know, component to the disease. And the other thing that I think can cause delay in diagnosis is that actually a lot of patients almost manage themselves quite effectively. And if you have quite mild disease, you can potentially do that. So if you're someone who exercises and who feels a lot better with exercise, that is part of your treatment. And so sometimes patients unwillingly or unknowingly, I should say, actually become quite dependent on their exercise to treat their symptoms. They just realize that they feel a lot better if they exercise or if they take anti-inflammatories as well. And so they don't necessarily need to look for additional diagnoses. They just manage themselves. But I mean, that's obviously one very mild end of the spectrum. And then unfortunately, the patients at the very severe end of the spectrum who just accept that they're doing without wanting to know more or without having access to doctors. I mean, that is a very real problem.
And Cathy, how easy is it to get to a diagnosis of X4 when you know, with all the different spectrums, you know, aura and all the rest of it, how easy is it to actually diagnose as a specialist?
Well, I mean, it can vary immensely. So I always say that if you are someone who comes to my office with an HLA-B27 result in your hand and x-rays that show sacroiliitis or an MRI that shows sacroiliitis, that's supremely easy for me. You know, that diagnosis is proven and I just need to help those patients to manage it. But if you're a more subtle case, or if you are HLA-B27 negative, or your symptoms are intermittent and the radiology isn't conclusive, it can be extremely hard. And you know, one of the things about rheumatology is that everything is a spectrum from very mild to very severe. And so the very severe cases are the easiest, but they're the worst outcome for the patients. So the biggest challenge is actually in patients who are in the early stages or have mild disease, and therefore you have to look harder. And you know, we don't always get it right. You know, rheumatology is full of gray zones, and even as a rheumatologist, we might be uncertain, and we might have to, I always say we're like detectives, and we have to keep looking, and we have to search, and we have to review the patient over time. And you know, often things will declare themselves over time. So sometimes the patients might not have psoriasis when you first see them, and 5 years or 10 years later they may develop psoriasis, and then we say, oh my gosh, that explains a lot of your symptoms, and that now all fits together. So it can be very difficult. And I think, I mean, I would never judge anyone, medical or otherwise, who is involved in a delayed diagnosis, because it's often very difficult in that time period to make the diagnosis. So when I see them 7 years later, it's become much easier because the symptoms are more prominent, or they're more radiological features. Things have changed over time. And I always tell the patients that, you know, time will always declare itself. The diagnosis will always declare itself over time. It's just how long we've actually got and how much damage happens in the meantime and how much pain is endured. So obviously the earlier we make the diagnosis, the better, but it's not always easy. So if it's not easy for us, then imagine how hard it is for general practitioners or for people who don't have access to doctors at all.
And how important is it to get to an early diagnosis? But let's talk specifically about AXPAR. How does your outcome if you get diagnosed early, would you have a different outcome to a patient that's perhaps carrying the AXPAR with them for many years before they get diagnosed?
Well, again, Miranda, the worse your disease, the more important it is to be diagnosed early. So the saddest cases are those with the most prominent symptoms that are missed and then treated late, and then there's damage. So whether that's damage in terms of ankylosis or reduced movement or peripheral joints, what you don't want in anything in rheumatology is to have irreversible damage. And so the earlier, you'll see any international guidelines will say that the earlier the diagnosis is made, the better for the patient. And that's better for them financially because they don't have to keep looking for solutions. And it's better for them in terms of psychological input because they know what the diagnosis is. And it's better for them in terms of long-term prognosis because they can receive more targeted therapy. But again, so I would just highlight that unfortunately the people who need the early diagnosis the most are those with the most severe disease, because once you have damage, whatever that damage is, whether it's fusion or ankylosis, which hopefully we don't let patients have these in 2021, but once you've got damage, you can't go backwards. So that's very important. And obviously there's the issue of pain and suffering along the way, and the patients often become quite despondent if they've lived with pain for a long time. So there's two separate issues. There's the pain issue and the quality of life issue, and then there's the damage issue.
So how important is it then that a patient that's showing symptoms of AXPAR or think that they have AXPAR, what is the importance of then actually seeing a rheumatologist as opposed to a general practitioner?
Well, I think, so as I mentioned before, if you don't have a specific diagnosis, one of the biggest problems that I would say, and this is a problem not just, with spondylitis, but with rheumatoid arthritis, for example, as well, is that when patients don't respond to one anti-inflammatory, the response usually from the treating doctor is just to give another anti-inflammatory and then to give a different brand and a different brand and a different brand. So actually the treatment is perpetually the same, but it's just a different version of the same thing, namely an anti-inflammatory. So that doesn't really help the patient. If you look at international guidelines, they will say that patients with inflammatory type back pain should receive an anti-inflammatory, and you can use two different anti-inflammatories because there's no doubt that some patients will respond better to one anti-inflammatory than another. So you might respond to one and I might love another one. And the patients always want me to tell them which is the inflammatory, and that doesn't exist because, because we're all different and our bodies are different and we respond differently. But going on to your fifth or your sixth anti-inflammatory and not really feeling better, that doesn't make sense. And it also doesn't make sense to then switch to codeine containing painkillers as well. So I think, so the first thing is you want to get the right treatment and you want to get the right education, and you don't want to just keep getting more and more of the same something, which isn't really helping. So that, I think that's the sort of starting point. And then you need the patients to be educated, because unfortunately lots of people just don't get the correct input in terms of exercise. And I always tell my AXPAR patients that exercise is written on their prescription. They have to exercise, and they think that they can't, or they're scared, or they're worried that they'll cause damage. But it's such a critical part of their management, and much more so in a way than if you have a non-inflammatory back pain, although all back pain patients should exercise. So I think it's giving them that knowledge, that that base from which to build, really.
I remember when I saw you the first time, and I remember when you sat and you said to me, there are two parts of my treatment plan. The one was the medication leg, and the other leg was the exercise. And I think you're quite right by saying that patients feel, you wake up and you go, oh, my back's sore, therefore I can't exercise. But in fact, when you do go exercising, you're not feeling great. You'll actually feel much better after you've done that. And I think the importance of exercise in AXPOR patients is underestimated in most of the
Completely. And I think the other thing is that sometimes you need to have your pain relieved so that you can exercise rather than not exercising because you're in pain. And that's quite a difficult thing because lots of people have this resistance to taking something for pain and then exercising. But in fact, this is a very specific illness, and anti-inflammatories, which allow you to then feel that you can comfortably exercise, are relatively safe if they're used carefully. So it's better to use something for pain and to be able to exercise and use that exercise as medicine than to take nothing for pain and do no exercise, because then you're really in trouble and you're going to become increasingly stiff. So if we educate the patients, and it does take a little bit of time to tell patients about how safe it is, to exercise and what they can and can't do and how they should take the anti-inflammatories, and to encourage them to exercise. And there's a lot of fear about exercise amongst patients. So we need to teach them how to build up gradually and how to, strengthen their core and to do low impact things before they consider doing high impact exercise. So there's a lot of input that's needed. And that's why things like these patient groups are amazing, because you can learn a lot from other people and from video. I mean, we have such amazing access to online resources of, support groups and exercise videos and things that can really help people significantly.
Yeah, I think you're right. AXPOR can be such a silent disease because you can't, in a lot of cases you can't see it. People will look at you and go, oh, it doesn't look like there's anything wrong with you. Meanwhile, back at the branch, your back feels like somebody's kicked you from behind. And I think because it is silent, it's important for people to speak out and to have confidence to live their best life, even when they have got AXPOR.
Completely. But also remember that, I mean, it is a worse disease in men in general than in women. And so the women often actually suffer for longer before the diagnosis is made, because it's often more subtle, and the diagnosing doctors think about it less often because it's more prevalent in men. So the women have a tough time getting to the right diagnosis, often missed for a very long time.
And I think what's quite important is that one has to realize that AXPOR is a disease. It's something that, as you say, there's a treatment plan that involves medication and exercise, and you can't really think it away. You have to treat it correctly. I thought we could touch on the role of biologics and medication. Perhaps we can unpack that a little bit. I mean, I know certainly a lot of our patients do not have access to biological drugs. And while AXPOR is not a PMB, a lot of people won't have access to biological drugs for a very long time. Does that mean if you haven't got access to these drugs, what does that mean as a patient with AXPOR in terms of outcome?
Well, again, you see, I think one of the important things is that patients need to know where they are on the spectrum of mild to severe. And so one of the dangers, I mean, I've highlighted the benefits of support groups and, patient information. One of the dangers is that you read about the worst case scenario patients, and that can be very scary. And even, I would say, even if biologics were much cheaper than they are, they're certainly not for everyone. And if you read international guidelines, they always say that the decision to use a biologic should be made between patients and doctors. And I have patients who have medical aid that would cover a biologic and probably should have a biologic, but they don't want it for whatever reason. And that's their choice. So it works in both directions. I think there are patients who would, really, really, really do well with a biologic and sadly don't have access to it. And then there are patients who do have access to it who would rather go a natural route. And so everything's a negotiated process. And I always say to patients that ultimately the patient is the one that has to take the biologic or take the silazepam or take the anti-inflammatory. So all that we can do is guide them and tell them what we think is best in their situation. And the other thing is that sometimes things change over time. So you might have a period of very severe and angry inflammatory back pain that then settles down, because there's so many things that we also can't measure. We can't measure the impact of stress. We can't always measure the impact of diet. And so each patient is unique. So I think the short answer is for very, very severe patients, biologics are completely revolutionary. And it would be amazing if all the patients that needed biologics could get them. But there are lots of patients who are at the milder end of the spectrum who actually don't need biologics and who can be managed quite well with a lot of education and exercise and physio and some anti-inflammatories and maybe some silazepam. So it's not that we have to lump everyone into the same basket. And we need to be very careful because we don't want patients who don't have biologics to feel that they're necessarily not being managed or don't have a good prognosis. We can do a lot with biologics, but we can also do a lot without. And so we need to look at each patient. We need to look at, whether they have overlapping diseases. We need to look at their risk of infection and where they live and their liver function. And, there are lots of different components to deciding what to do for each patient. And there are patients where I put them on biologics and even I'm disappointed with the outcome. And why that is, who knows? It's just, again, the fact that we're all different. So there are patients where I try biologics, and if the patients don't get better, we might agree after 3 months or 4 months that that's not the right treatment for that patient, but at least we've tried. So, there's really a myriad of different things that we need to consider when we treat each individual patient. And it's complicated, and it might change for each patient at different times in life as well.
I think part of the important things that you've just spoken about is that one can have stages of your disease being extremely active, and then you can go for months without even knowing what pain is, and to try and get to what it is that flares up your disease can also be quite important. If it's stress that flares up your disease, or if it's maybe lifestyle changes, that's not great. I think there's so many unanswered questions for that, as exactly what is the golden standard for all of that.
No, definitely. And I wish that we could be entirely scientific about it. I wish that when we saw a patient, and like if I saw you for the first time and I said, yes, this is the diagnosis, let me do a genetic test and see what are your aggravating features and which drug is best for you and what's your prognosis. And I think that would be amazing. That's what we're looking towards in the future. So targeted treatment for each individual patient. And at the moment, we have this amazing advance, which is biologics, but we're still a little bit blind. And how do we decide whether you're going to respond to one biologic or another, and whether the next patient is going to respond to the same drug or a different drug? And so we have this amazing scientific progress, but we're also still a little bit shoot in the dark, to see for each individual patient what's the best. I mean, I always say that we once did a rheumatoid arthritis study of a new biologic, and the patients, so on that study, they all got biologics for 5 years. And at the end of that 5 years, obviously the study came to an end. And a lot of the patients that had been on that study actually didn't have medical aid. So at the end of that time, unfortunately, a lot of them had to stop biologics altogether. And some patients flared immediately, and some patients flared 6 months down the line or a year down the line, and some patients just stayed in remission. So again, if you'd asked me, which of those patients was going to be in which group, I probably would have got it completely wrong. So it's very difficult to predict, and that's why we need to keep track of our patients. And we also need to be, as doctors, we need to be cognizant of the fact that sometimes we are very surprised. So sometimes, I mean, I had one particular patient who took a specific probiotic and did extremely, extremely well. That was with his angstpon, extremely and surprisingly well. for quite a while without a biologic, just through changing his diet and various gut things. In the end, he did go back onto his biologic, but what I'm saying is there was definitely a time where he was managing his symptoms in a way that I thought was surprisingly good, you know. So yeah, it's a very tricky situation, but I think the thing that I would say is that we don't want to miss the boat. So I will always tell a patient, if I really believe strongly that it's very important for them, if at all possible, to take a biologic, because I don't want them to come back in 3 years or 5 years and for me to see damage, because then that's really, you know, that's a failure of medical treatment for sure.
Perhaps we could spend a moment chatting about flaring and how you manage yourself. I mean, maybe you could give us some words of wisdom when you're feeling great, you're feeling great one morning, you wake up and it feels like somebody drove into you with their car, and now you're in the middle of this flare, and then especially if you haven't had a flare for a while, what would you say what would you put in your toolbox to manage those times of severe pain?
Well, I think so. The first thing that I would say is to try and tell the patients not to be too disappointed, and also to not, because it is disappointing, especially when you've been good for a while. And mostly I try and tell the patients to not completely overthink it, because I think, first of all, you imagine the worst. You imagine that this is the beginning of a very long, very bad phase, which is not necessarily the case. But I mean, that's our natural tendencies. We always think of the worst. So try and encourage the patients to look at a short time frame rather than imagining the rest of your life, you know, with negative thoughts. And the second thing is just to say that often the patients spend so much time and emotional energy thinking as to why or what or how the flare began. And sometimes you can identify something. If, for example, if you're one of those people who has a urinary tract infection and that tends to set off a flare, then you understand that. Or if you have a, you know, like a diarrheal illness and that sets off a flare, you understand it. But for a lot of patients, the reason that they flare is unknown or unmeasurable. So again, that comes down to stress, or is it a change in diet? And I think we spend so much emotional energy trying to figure it out. And especially for people who have been very careful, for example, about their diet or something, they feel it's like a personal failure that they've had a flare. But I think that we have to teach people that the disease often has a life of its own, and it's not a personal thing. The disease does its own thing, and so we need to kind of not be too weighed down by it, and then to treat it as best we can in the short term, and then deal with the longer problems if they should arise. So to be kind to yourself, you know, if you can't exercise for a while, then you can't, and if you need more anti-inflammatories or painkillers for a while, then you need to do that. And not, I always say, don't be a martyr. If you're in pain, you know, then you need to manage that pain in whichever way is going to work for you. And don't be someone who doesn't take anything or doesn't get treatment, whatever that might be, just because you fear, you know, the consequences. Yeah, and if you feel down and despondent, actually part of the treatment is to get your pain better, because then you'll feel much better in yourself. So I think it can be a bit of a negative spiral, and sometimes you just got to kind of overcome that downward spiral by breaking the cycle of not sleeping and being down and having pain. You've got to break it in as many ways as you can. So if that involves, you know, changing exercise and getting into a warm pool, and if it means taking a few more anti-inflammatories or altering your exercise, or, you know, sitting less at your desk, whatever it involves, then you've just got to do that for that particular time period. I don't know if that makes sense.
Yeah, I think managing your own expectations of your disease and yourself becomes vitally important, because I mean, what we often see with our patients is that the experience is not the same for every single, you know, every person has a different experience. They have different emotions, they've got different treatment plans,
for sure,
medicines or not. And if it's working for you, it doesn't mean it's not going to necessarily work for somebody else. So I think it's important that patients are not scared to be experimental and have that open conversations with their specialists. Say, listen, be open to try new things perhaps that you didn't think was possible. I thought,
and I think they need a lot of permission to be sore. Sometimes, again, especially women perhaps are very very sort of just get on with life, and then when they sore, they need permission to be able to say that that's okay, and that they need time out, and that they need extra relief in whatever way. So I think that's where we as doctors can tell them to kind of relax a little bit and be kind to themselves in the process, and not get bogged down.
And I think it becomes quite difficult if you think about it. When you see your rheumatologists, I'm lucky if I see you once a year. In a lot of cases, patients have to travel far to get to their specialists. And that's where a support group does become valuable, because you can lean on other patients around you. I wanted to, one of the topics I really didn't want to miss with you this evening is, as we were getting ready for our vaccination rollout, I think one of the big questions from all of our patients is, yes, we've got an autoimmune disease. A lot of us are on biological, medicines, and what are we supposed to do? Do, vaccinations, not vaccinations? I think that's the big question, because the reality is knocking on everybody's doors as we're getting ready. So I think this would be a valuable conversation to, share with our patients, the way forward.
Sure. It's definitely been a journey, the vaccination journey. And so my first answer would be that everyone who has the option to be vaccinated should be vaccinated. That's ideally what we should be saying. And the second thing to say is that any autoimmune disease, whatever it is, whether it's rheumatoid or lupus or Angst-Bond or psoriatic arthritis, does not necessarily in any way make your outcome any worse with the vaccine. So you are not more predisposed to side effects. You are not more predisposed to a flare. The data that we're getting through now is very good. And so the patients don't need to be anxious. You should be vaccinated. That is definitely going to be safer for you in the long term. Everyone should. If you feel strongly that you want to wait a little bit, and as I say, every month that's going by, we're getting more and more information. So we're learning all the time. But at the moment, the first thing is just to really, really, really encourage everyone and to say you do not need to be more anxious than anyone else. There is no increased risk of having a flare of any autoimmune disease, nor of being worse after your vaccine. The thing that is causing a bit of confusion is about the timing of the vaccine and what you do in terms of biologics or other drugs. So I did say to Miranda, I've got very good summary articles that I'm very happy to pass on, and then you can email to your members. And these are also based on international guidelines. So the one that we've been working from is the American College of Rheumatology. And the only drug that really needs to be adjusted is methotrexate. So when you have your vaccine, you should skip your methotrexate for 2 weeks after each dose. And that just is a very specific reaction to methotrexate, and it just allows your body to make a better antibody response. If you've just had a methotrexate dose, and then you get the message that you can go for a vaccine, it doesn't mean that you can't have your vaccine or that your response won't be perfect. It just be, and so you can proceed. But if you have the opportunity, if you have the warning and the time to skip 2 doses of methotrexate after your vaccine, the first and the second doses, you should. Most of the biologics, all the ones that we use for axial spondyloarthropathies, are actually safe to continue. So you actually don't have to skip any doses. The only biologic that needs adjustment is MabThera, which I guess most of your patients would not, your support group patients would not be on. So in general, The vaccine is safe for everyone. Everyone should get it unless they are extremely immune suppressed. So that's your chemotherapy patients and your patients on very high doses of prednisone. But your average rheumatological patient should please, please, please have the vaccine and not be anxious and just skip their methotrexate for 2 weeks after each dose, ideally.
Well, that's fantastic for that update. And very encouraging as we're all getting ready for this big rollout, which hopefully life can return back to normal.
And I think there's still a lot of anxiety actually out there in terms of biologics and COVID in general. And you know what we've learned is that actually the patients on biologics do remarkably well with COVID, perhaps in some cases even better than patients not on biologics. And that's because the patients who really do badly with COVID have this whole cytokine storm and immunity kind of goes a bit haywire. And if you're on something like a biologic, it actually keeps your immune system relatively calm. And so, whereas when COVID was first around, we were so panic stricken that all our immune compromised patients were going to really do badly. That hasn't really been the case. And in fact, there were quite a few patients in the beginning where their biologics were stopped because there was this fear that COVID was going to be worse in these patients. And that caused a lot of problems for those patients because they tended to flare. And so what we've learned in the last year or 18 months is actually that continuing your biologic is actually safe and is not something that we should be panicked about. And again, we need to look at each individual patient and their risk. But in general, continuing with the biologic is completely safe. And that's happening all over the world.
Yeah, I guess if we look at the stats that's going around everywhere, everybody should get vaccinated as soon as it's available to the individuals.
Yeah, but again, you know, I do understand that there will be people who don't want to, and in those cases, they're going to depend on the people around them being vaccinated just to reduce the spread of COVID in general. But I think that in terms of travel and in terms of protecting oneself, all patients ideally should be vaccinated.
Thank you for that advice. Everybody's been hanging on to hear that. I'm most sure of it. I thought in closing, if we could, if there was any parting thoughts that you could, you know, you obviously speaking directly to AXPOR patients. I think what came across quite strongly this evening from yourself to patients is not to be too hard on themselves and not to sweat the details. I think that was a very important message that you've given us this evening. If there was anything else that you could leave with our patients as a leave behind, you know, dealing with this disease that you can't even spell, let alone pronounce, what would that be?
Yeah, I think, Miranda, I think the thing that I would say is, you know, if you live with any chronic disease, it's not an easy thing. And sometimes, you know, patients come to me and they say, oh, you're going to be so cross with me. I stopped this, or I changed this, or I did that, or I didn't do this. And I always say to them, I might be disappointed if they've suffered as a consequence. I might be sad for their pain. But actually, if you live with a chronic illness, it's very hard, and your doctors don't have to swallow the pills or take the injection, you know. So I always say, I will never be cross with a patient, and it's completely normal if you have a chronic illness to go through phases where you feel people don't understand you, to feel that your doctor doesn't understand you, to feel that you're going to flush all your medicines down the toilet. That is normal, you know. And if you gladly accept your diagnosis and never feel cross or angry or frustrated, that's abnormal. So I always think that having a chronic illness, it's not an easy thing at all. And so we need to be cognizant of that. And you will always read about people, I always say, who took ginger and were miraculously healed, and you'll read about people who are in wheelchairs. And so you will always read about the best and the worst. And, you know, and each person's family is different, and each person's response to drugs is different. You know, there will be people who can pump themselves full of drugs and never have one side effect. And then there are other patients who will just look at a medicine and feel ill. So everyone is different, and we have to be, and each person's disease is different, and even within each individual, that disease course will be different at different times, as we've discussed. There'll be good patches and bad patches. So I think that knowledge is power, and I think that yeah, I'm not sure what else to say, but chronic illness is not easy. And we need to also not forget the other things. And I think you write about this quite a lot. We need to not forget about sleep, and we need to not forget about exercise, and we need to not forget about antidepressants if they're necessary, and we need to not forget about psychiatrists or support things. You know, a lot of alternative therapists, whether they be chiropractors or physios or whatever, have a very important role to play, in more so for some people than for others, but they all fit into the puzzle in some way for each person. So there is no perfect recipe, and that's very hard. And you know, I mean, there's no perfect doctor either, and it's hard for us sometimes. It's hard for us to be 100% for each patient, because we also get busy and distracted. So you know, it needs a little bit of give and take from all sides. But I think the patients that are knowledgeable really do better, that's for sure.
I think an educated patient definitely goes a long way. You know, the more you know about, you know, certainly what's going on around you, the more better you can deal with what's going on around you.
And you know, an educated patient often gets better treatment because they challenge their doctors more, they fight more, they look for different doctors, for different therapists. You know, they often do better. And sometimes that's what doctors need as well. You know, and for patients who don't have access to a rheumatologist, they can still challenge their doctors, or they can write emails, or they can get online support. You know, like there are lots of things. So rheumatologists are not the be all and end all either, in many ways. There's some very good general physicians who can manage these cases very well, even good GPs who do a good job.
I think also to have a team around you, which one would be a rheumatologist, then it could be a physio, it could be somewhere that you need to train with you so you can stay motivated. I think if you got that recipe of the soldiers you need in your team, then I think that's half of the battle won. We just wanted from the association to thank you so much for spending some time with us this evening. I mean, obviously, from a personal point of view, you've been my specialist and my saving grace for many years, but you've also been a great supporter of our association, and we really appreciate that. We couldn't support our patients, obviously, if we haven't got support of rheumatologists, and I know if there's ever anything we needed from the association, I could always knock on your door, and you'd be the first one to offer to help. So I just really wanted to say a heartfelt thanks for that. And
most welcome.
And then I'll see you at the Cape August in October.
Well, I must say, as a person, you're a very good advertisement for a motivated patient, and I think that's fantastic. So you practice what you preach, which is good.
Good. Well, I might not be over the inline. You might have to wait at the inline for some medicine. You know, you'll be finished 4 hours before me, but I'll get you over there.
It's been a pleasure chatting to you, and thank you for all your hard work.
Oh, Dr. Spargo, thank you so much, and have a wonderful evening.
You too, Miranda. Take care. Good night.
Good night.